Hi everybody, you are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering and evaluating medical education programs worldwide. Today we are going to speak with Brian Tomlinson, professor in the Faculty of Medicine of the Macau University of Science and Technology. This podcast, The Ongoing Role of Beta Blockers in the Cardiovascular Disease Treatment Paradigm, is part of the continuing medical education program entitled Blended Learning Journey on Cardiovascular Disease and Hypertension. The target audience for this program is clinicians, including cardiologists, internists, and general practitioners, nurse practitioners, and other healthcare professionals who manage patients with hypertension and heart failure.
Hello, I'm Brian Tomlinson. I'm from the Macau University of Science and Technology, and it's a pleasure to speak with you today about this topic regarding the use of beta blockers. The learning objectives of this talk are firstly to characterize the physiological features of patients with coronary artery disease and heart failure that indicate including beta blockers may be an appropriate treatment strategy. Secondly, to describe the mode of action of beta blockers as relevant to cardiovascular disease and heart failure treatment. And thirdly, to consider utilizing beta blockers as part of an effective risk-reducing strategy in patients with concomitant coronary artery disease with prior myocardial infarction and diabetes mellitus.
Which patients benefit most from beta blocker therapy?
The patients that benefit most from beta blocker therapy are quite a wide range. Beta blocker treatment is appropriate for a wide range of patients with cardiac disease. And also various other patients with non-cardiac disease can benefit from beta blocker therapy. If we think about it historically, beta blockers were first developed for the treatment of coronary artery disease, and then they were found to be effective for the treatment of hypertension and subsequently for heart failure. They're also indicated for the management of other conditions, including cardiac arrhythmias, aortic dissection, portal hypertension, and then less common conditions, including the long QT syndrome and hypertrophic obstructive cardiomyopathy. Hypertension and related diseases and conditions such as heart failure, ischemic heart disease, obesity or obstructive sleep apnea are often accompanied by activation of the sympathetic nervous system. And this makes beta blockers a pathophysiologically appropriate treatment for individuals with these conditions, elevated blood pressure and the related cardiovascular conditions. In fact, in most of these situations, it is the beta-1 selective beta blockers which are the most appropriate to reduce the sympathetic stimulation on the beta receptors in the heart. Additional properties of beta blockers may be useful in certain circumstances. For instance, labetalol with additional alpha blocking effect is very useful in acute hypertensive emergencies. So again, which patients benefit most? Well, beta blockers are considered to be first-line therapy for patients with coronary artery disease and those with heart failure with reduced ejection fraction, abbreviated as HFrEF. In HFrEF, beta blockers are considered as disease-modifying medications and a mainstay treatment for patients with this condition, and they influence the long-term prognosis of patients with HFrEF. The recent European guidelines for HFrEF management recommend beta blockers as one of the first-line therapies in patients who are clinically stable and euvolemic. Beta blockers should ideally be initiated in the hospital setting after the patient is hemodynamically stabilized. Of course, this indication is limited to the beta blockers that have evidence in this area: bisoprolol, carvedilol, metoprolol succinate, and nebivolol. So these are the beta blockers that have shown beneficial outcomes in patients with heart failure with reduced ejection fraction. Of course, they are used in combination with other treatments which have shown outcome benefits, the angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, and more recently, these have been somewhat replaced by the angiotensin receptor neprilysin inhibitor, the ARNI. And then there are the mineralocorticoid receptor antagonists, which are also indicated for those patients with HFrEF. And they may also need diuretics in certain circumstances where there is fluid overload. Then, of course, more recently, the sodium glucose cotransporter 2, SGLT2 inhibitors, have been shown to be beneficial, on top of all these other treatments in patients with heart failure with reduced fraction, but also in patients with heart failure with preserved ejection fraction. So nowadays, in patients with HFrEF, there are these 4 pillars of treatment: beta blockers, ACE inhibitors or ARNI, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. These are the guideline-directed therapies for HFrEF. But what about heart failure with preserved ejection fraction, or heart failure with mid-range or medium-range ejection fraction? What is the role of beta blockers there? The guidelines previously suggested there was no specific drug treatment for HFpEF, until, of course, recently the SGLT2 inhibitors have shown benefits. But it's interesting to look at some of the trials with beta blockers, such as the Seniors trial with nebivolol. In that trial in heart failure, they did not select patients with low ejection fraction. And in fact, the outcome appeared to be beneficial in all of the patients. And in a pre-specified subgroup analysis, there was no difference in primary endpoint in patients with reduced compared to patients with preserved ejection fraction. So there is some evidence from that study that beta blockers may be useful in heart failure with preserved ejection fraction. And in fact, many of the newer trials in heart failure with preserved ejection fraction were using beta blockers as a background therapy. For instance, in the Emperor Preserved study with empagliflozin, over 85% of the patients were taking beta blockers at baseline in both placebo and the empagliflozin treatment group. So it would seem that the doctors treating these patients with heart failure with preserved ejection fraction consider that beta blockers are a useful treatment for a large proportion, even though they may not be recognized as guideline-directed therapy. So we may have to consider that beta blockers could be used in quite a wide range of patients with heart failure, although, of course, they're much more clearly indicated in those with heart failure with reduced ejection fraction. If we turn our attention to coronary artery disease, beta blockers are recommended as a first-line treatment for patients with coronary artery disease in the most recent guidelines. And this is not only to control heart rate and relieve symptoms. There are some studies suggesting that they do have a beneficial outcome. There was a systematic review and meta-analysis published in 2023 that found that beta blockers, in combination with routine treatment, significantly reduced all-cause mortality in patients with coronary artery disease who had diabetes. So this particular combination, diabetes mellitus and coronary artery disease, does seem to be a particularly useful group who would benefit from beta blocker treatment. And there are other studies that show that early and long-term beta blocker treatment does reduce mortality and reinfarction in certain patients with coronary artery disease. Then, of course, patients with coronary artery disease often have additional risk factors or other conditions such as arterial hypertension and high levels of cholesterol. And these contribute to the increased likelihood of developing cardiovascular disease, particularly coronary artery disease. And if one thinks about these on a larger scale, it's very important to detect these at an early stage. And in primary prevention, these conditions are often overlooked until it's a bit too late. And so I think it's very important to identify these underlying risk factors and to treat them effectively. And there are certain groups where this is particularly important. For instance, women who are transitioning to the menopause develop a much greater cardiovascular risk. And it's important to identify this problem and to introduce risk-reducing strategies and encourage healthy behaviors and treatment adherence, particularly in this type of group. And of course, in recent years, there are various innovations in healthcare practice which may help to overcome some of these problems, such as telemedicine and telemonitoring, which have been shown to be useful in the management of hypertension. Now, furthermore, patients with hypertension are overall a group who can benefit from beta blocker therapy in certain circumstances. Of course, in recent years, several hypertension guidelines have removed beta blockers from their previous position as one of the first choice drugs for the treatment of hypertension. But if we look at the 2023 European Society of Hypertension guidelines, they have put the beta blockers back in a more prominent position because they reviewed the evidence and found that beta blockers do lower elevated blood pressure as effectively as other major antihypertensives, and that beta blockers do sizably reduce the risk of cardiovascular outcomes in placebo-controlled trials, including the risk of stroke. The slightly older guidelines, the 2018 guidelines of the European Society of Cardiology and the European Society of Hypertension, do point out that beta blockers are less protective against stroke than some of the other antihypertensive drugs. And that was one of the major reasons why beta blockers were not considered as a general first-line treatment for hypertension. Also, beta blockers have been associated with certain adverse effects, such as increased risk of depression or erectile dysfunction. But again, the evidence suggests these have been overemphasized and are not a common problem with the beta-1 selective beta blockers. So although the hypertension guidelines, for instance, the 2018 ESC, ESH guidelines, didn't recommend beta blockers in general, they do recommend them in certain specific circumstances in patients with hypertension, such as those with symptomatic angina, for heart rate control, post-myocardial infarction, heart failure with reduced ejection fraction, of course, and importantly, as an alternative to ACE inhibitors or angiotensin receptor blockers in younger hypertensive women who are planning pregnancy or of childbearing potential because of the potential teratogenic effect of these drugs which inhibit the renin-angiotensin system. And beta blockers are also recommended for hypertension in patients who have atrial fibrillation and certainly in acute cases of aortic dissection. Another point that favors the use of beta blockers are patients with elevated resting heart rate. And this is present in quite a considerable fraction of hypertensive patients, particularly young or middle-aged patients with mild to moderate hypertension, the so-called hyperkinetic circulation. So elevated heart rate is considered to have detrimental effects on the cardiovascular system. It increases cardiac work, increases myocardial oxygen demand, it augments arterial wall stress and decreases arterial distensibility and facilitates coronary plaque disruption. So overall, increased heart rate seems to be an independent risk factor in the hypertension population. And so treatment with beta blockers has been considered an important first-line treatment for those hypertensive patients with a high resting heart rate, usually considered with values over 80 beats per minute. This, of course, is not supported by randomized clinical trials, but it is a general recommendation in hypertension guidelines, such as the 2018 ESC, ESH guidelines. Those are some of the situations, quite a wide range of situations where I think beta blockers have a special place in the treatment of these various cardiovascular conditions.
What are the barriers to prescribing beta blockers for patients with complex needs, particularly coronary artery disease and heart failure with reduced ejection fraction?
Thank you for that question. That's important because patients are often not treated adequately with beta blockers in these situations. Physicians often underuse beta blockers in patients with heart failure with reduced ejection fraction or coronary artery disease, partly because these patients often have coexisting comorbidities, and it may be inappropriately considered these comorbidities are contraindications to beta blocker use. For instance, conditions such as chronic obstructive pulmonary disease, diabetes mellitus, peripheral arterial disease, ischemic heart failure, chronic kidney disease are often present in these patients with heart failure or coronary artery disease, then they may be considered as a potential contraindication to the use of beta blockers, whereas in reality, many of these conditions are actually positive indications. For instance, it has been recognized that beta blockers may mask the symptoms of hypoglycemia and thus impair awareness, particularly in patients with type 1 diabetes or patients with type 2 diabetes who are taking insulin. But hypoglycemia is becoming less common nowadays. The treatment for diabetes, particularly type 2 diabetes, really tries to avoid hypoglycemia. So I think this has become less a contraindication. It's also been thought that beta blockers have adverse effects on lipid parameters and diabetic control in these patients. But again, that's more of a problem with the non-selected beta blockers. And the beta blockers, which are highly beta-1 selective, are largely free of those metabolic adverse effects. And in fact, in chronic obstructive pulmonary disease, although there's been the concern that beta blockers may worsen the respiratory disease, these patients often have underlying cardiovascular disease. And overall, the studies in this situation in patients with combined coronary disease and COPD, beta blockers show a beneficial effect. They are protective and safe in these conditions. So rather than being a contraindication, one should consider it as a positive indication. And again, it seems to be important to use the higher doses of beta blockers. These are associated with lower rates of all-cause mortality, progressive heart failure, and sudden death in studies with COPD. Again, the important characteristics of beta blockers that make them appropriate first-line treatment for patients with coronary artery disease or heart failure with reduced ejection fraction are the beta-1 selectivity. This provides the beneficial effect and is much less likely to have the adverse effect on these conditions. Non-selected beta blockers are associated with worsening of bronchial asthma, maybe not COPD, but certainly if there's reversible airway obstruction. And even some of the drugs which have some degree of beta-1 selectivity, such as atenolol, may have adverse effects on bronchial asthma. Another concern, of course, is erectile dysfunction, impotence, and that again seems to be more of a problem with the less selective beta blockers, and those which are highly beta-1 selective or have some vasodilating effect don't seem to be a problem in terms of causing impotence. Similarly, in the conditions of metabolic changes, low HDL and increased triglycerides, these are mainly a problem with the non-selective beta blockers and to some extent with less beta-1 selective drugs like atenolol, because atenolol has been shown to be inferior to some other antihypertensive drugs in at least two large randomized controlled trials, the LIFE study and the ASCOT study. And some of the disadvantage there may be that the treatment with atenolol didn't lower the blood pressure to quite the same extent, and it does have some of the adverse effects on metabolic profiles and other things similar to non-selective beta blockers.
Are beta blockers still important?
Yes, of course, since the development of beta blockers and the large studies that have shown the benefits, particularly in heart failure with reduced ejection fraction, there have been a lot of further developments in the treatment of cardiovascular disease. For instance, a very recent study, which is published in the New England Journal of Medicine in April this year, was the REDUCE-AMI study. This is a study in patients with acute myocardial infarction and preserved ejection fraction. So they deliberately selected to have preserved ejection fraction, and they were randomized to treatment, long-term treatment with beta blockers or without beta blockers. And in that study, there was no significant benefit of randomizing these patients with preserved ejection fraction, recent acute myocardial infarction, to treatment with beta blockers. There was also no obvious adverse effect. Now, looking at the trial carefully, it's an open label trial, and there were major exclusions, which were indications or contraindications to beta blocker treatment. They used two particular beta blockers, either metoprolol or bisoprolol, but they didn't titrate the dosage up to the dosages that had been used in the HEF-REF studies. And again, looking at this trial, in the patients who were not assigned to beta blockers, over the first year, 14% of patients were put on to beta blockers. So obviously the specialist physicians who are treating these patients post-myocardial infarction felt that quite a fair proportion actually needed beta blockers. So although this study suggests that it's not essential to put all patients post-myocardial infarction onto beta blockers, particularly if they've had effective revascularization. I think nowadays, with the percutaneous intervention and very effective revascularization, the risk is much reduced. And maybe in patients who have normal ejection fraction or preserved ejection fraction, more than 50%, the benefit of beta blockers has become less. So this group may be not so clearly indicated to have beta blockers. I mean, of course, this does not apply to patients with reduced ejection fraction. But I think this just demonstrates that nowadays we do have new interventions which maybe produce such benefits that the potential benefit of beta blocker is much reduced, and the overall indication is not so clear as it was before. But again, it does show that beta blockers may still be needed in particular circumstances in these patients, although it may not be an overall indication nowadays when new guidelines come up for patients post-myocardial infarction. Perhaps beta blockers will not be overall indicated for those who have complete revascularization and have a normal ejection fraction. So I think that there are advances in other forms of treatment, and they may reduce the benefit of beta blockers in certain situations, but there is still going to be a very wide range of patients who will benefit from beta blockers, and I think this needs to be clarified in subsequent guidelines. So, as I've said, there are many different patients with cardiovascular disease who will benefit from beta blockers, and overall the benefit is greatest by using the beta blockers, which are highly beta-1 selective, and those which don't have some of the adverse effects of non-selective beta blockers.
What take-home messages do we have at the end of this podcast?
The take-home messages I'd like to emphasize are that there is a wide range of cardiac diseases that benefit from the use of beta blockers. I think first and foremost, it's heart failure with reduced ejection fraction. The certain beta blockers which are indicated for that are clearly very important in the treatment of that condition. And in higher risk patients who have additional cardiovascular problems, it becomes really essential to use the appropriate beta blockers and to try to increase the dose to the guideline-directed dose or the maximum tolerated dose. Also, in patients with coronary artery disease, there's a very strong indication for beta blockers, not only to improve the symptoms, they are a first-line treatment for the symptoms of coronary artery disease, but also in certain circumstances, they will reduce the morbidity and mortality. So those two conditions, I think, very clear indications for particular beta blockers. In hypertension, again, there's a wide range of additional factors which make beta blockers an appropriate treatment to use in patients with hypertension. So we still have a wide range of cardiovascular diseases that have benefits from the use of beta blockers.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.